Hello, PsyQ community. Dr. Rachel Self here with Otsuka Neuroscience Medical Affairs. Thank you for tuning in today as we discuss viruses, vaccines, and long-term consequences, an update on the SARS-CoV-2 pandemic. This is a follow-up from last year's series on viruses, vaccines, and inflammation, where we had a really nice discussion in a three-part series with Dr. Gary Pattee. So let's dive in and see where we are over a year and a half into the pandemic. Joining us today is our featured speaker, Dr. Gary Pattee, clinical neurologist for Neurology Associates. Dr. Pattee is also assistant professor and clinical instructor for the Department of Neurology and co-medical director for the Muscular Dystrophy Association Clinic within the University of Nebraska Medical Center. He also serves as clinical instructor for neurology in the Lincoln Family Practice Residency Program. Dr. Pattee has extensive experience conducting preclinical and clinical trials research, as well as numerous different scientific publications, abstracts, and oral presentations, including what he's providing for us here today. So thank you, Dr. Pattee, for joining us. This program is paid for by Otsuka and Lumbeck, and Dr. Pattee is getting reimbursed for his time with us today. We won't go through a lot of detail here. These are our rules of engagement. Take time and review this at your own leisure, but please note you will not be offered continuing medical education for today's program. Briefly looking at our objectives for today, we are going to be providing some updates on the novel coronavirus pandemic with respect to the SARS-CoV-2 virus. We'll look a little bit more into detail about differential presentations of viral infection and some of the prevalent circulating variants at today's presentation. And finally, we'll give an update on things related to vaccine development and currently available vaccines. Without further ado, let's take a closer look at what we know 1 year into the pandemic. Dr. Pattee, would you like to walk us through some of these statistics and talk a little bit about where we are now, probably closer to a year and a half or more into the pandemic?
Sure, absolutely. Well, thank you so much, Rachel. It's a pleasure to be back and reviewing this topic. Just as a quick introduction, as a clinical neurologist, I care for a lot of patients who have been afflicted by COVID. And so this is a topic near and dear to certainly our hearts. As you can see from this slide, there's a high emphasis on the type of individual that might be affected. 90% of COVID-related deaths report in countries with the highest obesity rates or highest BMIs. It's a topic of a lot of research and discussion. There's data to suggest the immune system may actually be impaired based on BMIs. And as you can see, it can triple the risk of hospitalization. It can affect the lung capacity and reserve. The ventilatory capacity with the patients with elevated BMIs is certainly afflicted and potentially making these patients more likely to contract this disease. Risk of death increases, and it may be linked to other vaccine responses, suggesting that maybe the flu, hepatitis B, tetanus vaccines may not actually be having quite as much of an effect in individuals with a higher BMI. 50% of patients who've been hospitalized with severe COVID-19 have also showed raised levels of troponin. We're going to touch on this topic again throughout the day. The concept of what injury to the heart takes place with this virus is very important, especially as there have been a lot of discussions on vaccine-induced side effects. We certainly know, and this statistic points it out well, that at least 50% of patients who have been afflicted by COVID, even if they have mild symptoms, have evidence of some involvement of the cardiac muscle or some cardiac damage.
Thank you, Gary, for walking us through that. We will be continuing this conversation of some of the differential presentation today. And I'll go ahead and put in a shameless plug for part 3 of our series, where you'll be taking even a deeper dive, talking with a psychiatrist as well as a patient caregiver expert and advocate on some of the differential presentation, which presents us with the perfect segue to dive a little bit deeper into this topic now. So if you wouldn't mind sharing a little bit of information about specific organs, specific immune-related reactions that can present with some of the patients that you've seen and that we know are presenting with COVID around the nation and the globe.
So absolutely. Just as a basic review, everybody understands that COVID is a coronavirus. it is manifested by something referred to as a spike protein. On this spike protein is something called a receptor binding domain that adheres to the ACE2 receptors within the endothelial lining of tissues throughout the body, predominantly the lung, the heart, but any vascular tissue. And as you can kind of see on the left, all the different organ systems can be afflicted by this particular virus, some more commonly than others. But just to review, it can lead, this virus, this severe autoimmune respiratory syndrome can lead to immune imbalances in general. So the immune system can be afflicted early on. What we've seen with the interferons you see on this slide, sometimes the interferon production and the amount of circulating interferons are reduced. Sometimes patients develop neutralizing antibodies against the interferons, which can drop their overall abilities to interact with the virus, preventing infection. Parts of the immune system can oftentimes become overwhelmed by this inflammation. It's referred to as a cytokine storm. And so we really, in that kind of a scenario, it's sort of an over-response to a COVID infection. We see it a lot in our young children. We'll touch on that here shortly. But this is a very dangerous syndrome. When the body's immune system is triggered to attack, it can do multi-organ damage. Now, the lower lobes of the lungs are most frequently damaged. Oftentimes, that's where the virus enters the body, and it can spread from then. As we discussed, the heart can be involved, but a third of the patients show cardiovascular symptoms, which might include a cardiomyopathy, where the pumping action of the heart itself is affected, pulmonary thrombosis, infection of cells lining blood vessels, myocarditis, inflammation of the myocardium or the sac around the heart can be identified. And as this last point suggests, differences by age cohort. So our elderly patients oftentimes are more highly afflicted, yet our younger patients may have these multi-system inflammatory syndromes or the multi-organ disorders. So all age groups are at risk.
That's true, and thank you for pointing that out. And I think it's interesting because that's really been an evolving story, right? From the beginning of the pandemic, where we heard so much more about elderly and more immune compromised being more at risk, and now the shift has really changed focus towards younger age groups and those who are not vaccinated, where we're starting to see much more of a differential presentation across those age cohorts. So
Yeah.
something to keep in mind and keep track of for sure. So we've heard a lot about blood types, and I know you're going to be providing a little bit of a Mythbuster section for our PsyQ community as well with my colleague, Jacqueline Canning, on this topic. But let's talk a little bit more about some of the pre-existing conditions, including, potential viral or vitamin deficiencies, as well as, what type of blood type people are and what type of risk that confers for COVID.
Well, of course, Rachel. So just as an aside, this slide actually was created, it's been a couple months at least. And at the time, there was a lot of emphasis on blood typing, and that certain blood types might make one more readily infected by this particular COVID. There was another larger study, however, that came out within the last month or so that really put a little water on this theory that the blood types likely didn't play a key role in those to be infected. So we're not focused as much on the blood typing as we were at one point, but as Rachel mentioned, this is an evolving story. It seems like every week new information is released and we learn more. What we do know is that vitamin deficiencies play a key role. The one neurologically that we always focus on is vitamin D. So vitamin D is an interesting vitamin. It's not only a vitamin, it's a hormone. And what we're seeing is that low vitamin D levels inversely have a secondary effect on elevation of the inflammatory cytokines within the system. So with MS, for example, it's a concern. With other viral syndromes, certainly with COVID, it's a concern. So we try to get people on vitamin supplements if they're not already on those. And it's not just vitamin D, but B and C have also been used. There's been some data that suggests maybe zinc, yet neurologists don't like zinc because it can lead to copper deficiencies and other kinds of problems. So we really kind of focus on the the BCD vitamins is our ABC approach. The last comment, the viral load. Now, this is actually something that is very interesting. It likely has to do with the amount of the initial bolus of viral exposure. So this is a virus that gets in the system and starts to replicate. And if you have a small exposure, a tiny amount, maybe 10 parts of the virus per million, it will replicate to 20 the next day, 40 the following day. But what if your viral load exposure were 1,000 parts? You can do the math and you can see within a few days, it can really kind of take off and become more infective. These other associated conditions such as elevated BMI, older patients, people with underlying immune disorders might be at a higher risk. So it's been something that we've really been focusing on, and the interferon comment on the prior slide was very important. Most of the patients that get very, very ill had very low interferon levels when they did analysis of that. So viral load is key, which gets back to the whole concept of masking and distancing and things that were with this new variant pretty much working its way across the country. We're rediscovering how important those preventive measures are.
Absolutely. And again, that's an evolving story as well with the Delta variant and people reinstating mask restrictions. And we're tracking that and hearing different news every single day. So it's definitely something that we aren't quite through everything as much as we would like to be. And to just kind of segue into a little bit more discussion around some of what now looks to be a bidirectional impact of the coronavirus with psychiatric conditions. So there's actually been quite a bit of information coming out to suggest that individuals with psychiatric disorders are more likely to actually become infected with COVID. We just saw in July of 2021 a large systematic review that came out, including over 90 million patients, showing that those with mood disorders are more likely to be hospitalized and to be more at risk of death by COVID. And you're going to speak much more to this in part 3 again, as you speak with Dr. Gaurav Agarwal, a psychiatrist who works with us, and Kathy Day from the patient and caregiver perspective. But if you could just take a moment and kind of walk our audience through a little bit of the differential presentation with respect to different psychiatric conditions that are mentioned on this slide and provide a little more perspective there, we'd really appreciate it.
Well, of course, Rachel. No, this is a fascinating slide for me because it's something that was a bit eye-opening just to see some of these statistics. And we'll go through each of these points individually. So point number 1, individuals with, as Rachel mentioned, underlying psychiatric disorders are 50% more likely to succumb to this virus, regardless of age, race, other comorbidities. This is, to me, an astounding figure, and I don't think we have a clear understanding of why this is, although it is interesting that in the world of psychiatry, schizophrenia in particular, there has been a lot of research over the years looking at the potential for an immune mechanism underlying the psychiatric disorder. And especially with schizophrenia, there have been viruses associated or thought to be associated with the onset. It isn't a proven theory, but it's one that has undergone a lot of work. It actually is one that our lab has looked at as well. So I find it very interesting, this particular statistic. Point 2, individuals with schizophrenia are 3 times more likely to die from this infection, which also is it's something that we don't have a good explanation for. I think plainly stated. Why would a particular psychiatric disorder put one at a higher risk of death? This is a question that a lot of reviews are asking. And it may once again have to do with what this particular virus is doing within the system. And it may not even be within the brain, but it could be in the gut microbiome. There's just a lot we don't understand. Point 3, studies indicate that a diagnosis of COVID is associated with increased incidence of a first psychiatric diagnosis, anywhere from 2 weeks to 3 months following the infection. This is also actually quite interesting because this is about the time when we may see immune reactions take place within the body as a consequence of the virus. And could those immune reactions be leading to changes within the brain, whether it's serotonin receptors or other pathways that could lead to psychiatric diagnoses? Certainly more so than we see with other infections that's listed on the slide. And then, as Rachel mentioned, mounting evidence suggesting a bidirectional association between psychiatric diagnoses and COVID. Soon we'll talk about another condition called the long haulers syndrome, but one wonders if the chronic fatigue, long haulers syndrome isn't actually also associated with some element of depression. And could that be part of this psychiatric bidirectional impact? We just don't have enough data on that yet, but these are all issues that are being investigated.
Absolutely. And just to piggyback a little bit on what you were sharing with our audience, Gary, I know that the National Institute of Mental Health, as well as NAMI and some of the other advocacy organizations, are actively trying to track the data, as you mentioned, and trying to figure out exactly what's going on. And they are very interested in the underlying immune dysfunction theory that we know goes around with a lot of different psychiatric illnesses, including schizophrenia, and finding other types of disparities. I recently just heard the statistics that if you are a Black and African American with a schizophrenia diagnosis, you're actually 20 times more likely to die of COVID, to get COVID and then have severe consequences. And there's a lot of speculation, just to kind of draw on one of the comments that you made, you know, trying to make rhyme or reason of this. We can't rule out, obviously, some of the social risk factors that might be related to those with a mood disorder or psychotic condition like schizophrenia. Just if they are employed, the types of jobs that they have are probably going to put them in exposure to other people a little bit more, as opposed to being able to work from home in front of a computer screen as much, whether or not they are homeless or live in a group home type of situation, as well as the propensity for being incarcerated, unfortunately. So a lot of those types of increased potential risk factors haven't always been pulled out of some of the meta-analyses and data that have been collected so far. So I think that's really interesting. And then just the growing evidence that we see for not only onset of a new psychotic disorder, but even a new mood or anxiety disorder for those that have a more severe presentation of COVID, who never had a psychiatric illness prior to the disease. So this bidirectional relationship that's starting to unravel a little bit more is absolutely fascinating to me. So I'm going to be tracking it and hearing what you have to say in part 3. So thanks.
Yeah, it's more information will be gathered, I'm sure.
Absolutely, absolutely. So to get a little bit deeper into the science, if you could share some of the information that we have right now about the mechanisms of pathology that we know SARS-CoV-2 inflicts upon the central nervous system.
Yeah, you know, so just to kind of comment generally on the CNS pathology, and I guess as a neurologist, what are some of the symptoms that we see, just to kind of just divert slightly? Well, as everybody knows, the inability to smell and taste is one of the first things that can be affected. Headaches are commonly seen. Sometimes we'll see seizures. But a high percentage of patients have a delirium or an encephalopathy, a confusional state. And it's interesting to try to understand what about this particular virus leads to that. So as we look at point number 1, this virus invades the lung first, as we mentioned. Yet the virus also, with immune responses against it, can spread into other organ systems, obviously the CNS. Through the ACE2 receptor interactions within the vasculature of the brain, we can see strokes, both venous and arterial. And what effect it may have on the next point, the glia and the neurons within the brain are also concerned. These also express the ACE2 receptors and are targets, of course, for the SARS-CoV-2 infiltration. And as we'll talk a little later, some of the variants may actually make some of these receptors more attractive. Third point, microglia. Now, these are the cells that deal with some of the immune mechanisms within the central nervous system. They can be affected by a lot of triggers: stress, gut dysbiosis, metabolic disorders, obesity, as we've discussed, physiological, cognitive aging. Other environmental risk factors could render individuals more at risk of developing neurological and psychiatric complications, even after complete clinical recovery from the infection. So it has to do with, well, what makes the condition linger? And there's different thoughts behind that, some of which we'll touch upon. Some of it also has to do with the immune system being triggered, some of the memory cells within the T and the B cell system, and some of the virus that may be continuing to exist in sort of an inactive form, but yet the immune system could still be triggering a response against it. And that may explain some of this long hauler or this long-term manifestation that sometimes people have. I think what's very difficult, at least for the patients I've cared for, is when they have cognitive changes. They're not able to perform cognitively as they had. It can be very distressing because A, there's no therapy for this, and B, there's no known length of time before they recover. It's literally the unknown, I think, that has most of our patients so troubled, as I would expect them to be. And this is something that with time, hopefully we'll get a clearer picture. Are there means or mechanisms we could focus on? I think reducing anxiety, improving sleep, working on slow exercise programs, anything that would help boost the body's immune system is in their favor. But there's a lot about the CNS pathology we still don't yet understand. But as it stands now, this particular organ system is affected with this virus.
Absolutely, yes. And again, this is an area where there's a lot of new information coming out almost on a daily basis. So it's going to be interesting to see how the story continues to unravel as we get more and more information. So to continue along those lines, we know that there's a differential presentation often in children. And they were calling this a Kawasaki-like presentation initially, and they've renamed it Multisystem inflammatory syndrome in children. Could you speak a little bit to our audience about exactly what this looks like and some of the perspective that you have on multi-inflammatory or multisystem inflammatory syndrome?
Well, absolutely. I think that as the name implies, this is a condition where multiple organ systems are inflamed in children with COVID infection. It oftentimes happens under the age of 5. Some of my I'm not a pediatrician, but my pediatric colleagues that are actually pediatric hospitalists are telling me about some of the cases they've had, and they've been devastating for these young people. This is probably a very good example of this cytokine syndrome. And as the points suggest, point number 1, typically these are young people, less than 21 years of age, presenting with basic symptoms of infection, fever, inflammation, at least greater than 2 organs that are involved. And they're so sick, they're almost always hospitalized. Now, there's no other plausible diagnoses, looking for sepsis, looking for shock syndromes. And they're positive for current or recent SARS-CoV-2 infection or exposure within 4 weeks prior to symptom onset. It's a pretty clear-cut case when those points are met, but that's in fact what they have. And a lot of it is supportive care for these young people. But I think it points home the key issue is that even young people need vaccination. And we have to find a way to protect them because there is really no way to know who's at risk. I don't know of any good data suggesting that children who have underlying pre-medical or pre-morbid medical conditions are at risk for this. This is afflicting the healthiest of kids. So we don't have a good understanding. As Rachel mentioned, it's a little like a Kawasaki disease, something we've known a lot about for some time, which is also associated with GI symptoms, toxic shock, clotting, acute kidney injury, respiratory involvement, a multi-system or multi-organ involvement disorder. With supportive care, most of the kids that, at least in our community, have come around, but they haven't all. Some of them have died from this condition. So it really pounds home how sort of unpredictable this virus is and how we really need to take it very seriously in all age groups.
Absolutely. Thank you, Gary. Yeah, and I think it just kind of underscores we don't know what the long-term consequences are going to be for kids who succumb to this multi-system inflammatory syndrome or adults who have the more severe presentation and those lingering or long hauler type symptoms. So it's something that we're going to have to keep top of mind and track. And that segues us into this sort of long hauler idea or some of these more long-term differences in the presentation. Could you speak a little bit more about that to our audience?
Yeah, as we've kind of alluded to, there can be a more chronic presentation that this virus presents with. Now, just kind of as an aside, Rachel, we saw a lot of these same features in our West Nile population from 10, 15 years back. And so there's not a big surprise. We know that a lot of times viruses just stay in the system. But running to the point, even mild cases can have life-changing effects. So a lot of people will use the I may just have a mild case, why get vaccinated rationale of not seeking vaccination. But what they don't really understand is that even the mild cases can have long-term effects. We've seen it with the cardiac involvement, and we can also see it with this chronic fatigue-like syndrome that these individuals may possess. Point two, many people who become severely ill experience the neurological complications such as brain fog, delirium. Delirium is very common, by the way. I would say that's probably one of the number one presenting cognitive features we see with COVID infection. Conversely, anyone presenting with delirium right now is being screened for COVID as one of the first issues we're looking for. Cognitive difficulties, including confusion and memory loss, may persist, and that's really the concern. That gets into, well, what areas of the brain were afflicted specifically by this virus that would lead to confusion, memory loss after the acute symptoms clear. And it gets down to probably a multifactorial approach. One thing we are focusing on is sleep cycle disruption, and the whole sleep cycle cascade is very influential on our memory and our cognition. So focusing on improving one's sleep patterns are one thing that we can work on, but a lot of it is just giving it time to clear. Fourth point, an increasing number of people have reported a crippling exhaustion and malaise, and that gets down to that long hauler, suggesting that something about this virus, whether continued immune activation or just a latent effect on the body's ability to recover, has been afflicted. You know, with other diseases, MS, for example, they can develop something called a central fatigue syndrome, and that's where neural damage just contributes to fatigue. We really don't understand that with MS, and it may be that we're seeing something similar here with this particular COVID infection. All of which points to, even though the statistics suggest 20 to 40% of people who get infected won't have symptoms, this suggests that, well, maybe they don't acutely have symptoms, but down the road, there could be other concerns.
Yes, thank you for that perspective. And we're going to have to talk offline a little bit more about the sleep and enhancing that, because that's something that is of great interest as well, as we've seen so many changes to sleep patterns and utilization of sleep enhancing medications as we've gone through this pandemic. So let's talk a little bit more about testing for the virus. Could you share a little information about the different types of viral tests that are available and sort of what they tell us, and how accurate and how often maybe these should be being done?
Yeah, so this is nicely laid out that you have the viral test or the antibody test. And if we just focus on the viral test, two basic types. There's the nucleic acid amplification test, which focuses on the virus's genetic material. Used commonly in laboratories, it's more accurate, sometimes takes a little longer to process than other test types. Now, the easier test, or the rapid test, is the antigen test, which, rather than genetic material, just focuses on the viral protein. May not be as sensitive as the genetic testing information, but it's easier to perform. Now, a positive or negative antigen result may need to be confirmed by the nucleic acid amplification test. There are different types of the rapid tests available. Just as an aside, we were flying back from Frankfurt, Germany a couple weeks ago and had our rapid test in hand, only to find that that particular rapid test was not accepted. They put us through a different antigen test there at the airport. I didn't realize there were that many different types, but the point, I guess, is that there are going to be different ways of testing for the viral proteins. And obviously, the nucleic acid amplification test is the most reliable of the two types. Now, the last point on the slide are the antibody or serology tests. And in essence, this is a blood study looking to detect the SARS-CoV-2 antibodies in the blood. Now, there's a lot of issues with this. There are some false positive, false negative issues that we don't totally understand or know the instance of. Probably most important to us is that whether these are IgM or IgG antibodies, we simply don't know. We don't know how long they'll last, and we don't know oftentimes when they formed. So it's a very black and white test that, if positive, suggests prior exposure, but it gives you little other information as to how long ago that exposure took place. But these can be used in a number of different scenarios. I know for a while they were using them after people had natural infection, with the understanding that once the antibody titer dropped, they might at that point want to undergo vaccination. But even that logic has kind of fallen a bit by the wayside, because we can't actually get titers as you can, as I mentioned, say with a West Nile or JC viral titers we commercially will screen. We don't have that ability with this particular testing. So it still is available. It's helpful if you want to see if somebody's had exposure before. But for making other decisions, there's still a lot it just can't offer as of yet.
Great. Yes, exactly. And it is very interesting. You were talking about the travel and been hearing so many different stories about those that are living or traveling ex-US and the different types of testing that's required, as opposed to, largely in the US, we're kind of still working on the honor system. So it'll be interesting to see how all of that plays out. And then when we finally get guidance on when you need to have those boosters for your vaccine. Remains to be seen. So talking a little bit now about some of the viral variants, obviously, this Delta variant is the reason that we are kind of still in the midst and in the throes of figuring out changes to travel and mask restrictions and things like that. Could you walk the audience through a little bit more about the viral structure? I know you've talked about the spike protein, but a little bit more about that and some of the variants that we know exist right now.
Well, sure. So don't be too alarmed by this slide. It's a busy one. We'll go through it. But more importantly, a lot of people ask me, what is a variant? Patients will say, what does that mean? What's a variant? Well, I think it's important to realize that with this RNA virus, we see mutations. In fact, our virologists will tell us that the RNA class of viruses have the ability to mutate every couple of weeks, in fact. And a variant is, in essence, just a mutation. And if we look at one particular mutation that we saw in this country early on, even last year, it was very common. It was the D614G mutation. I'm going to read through the text here because I think it explains a lot of what the variant can do. We talked about spike proteins. These are the proteins sticking out of the virus that are the docking proteins when they adhere to the cell wall of the host or the individual they're invading. So these spike proteins bind to receptors on the human cell. We call these the ACE2 receptors, which helps the virus enter the cell and replicate and continue to spread. Now, a spike protein is made up of 3 smaller peptides in an open or closed orientation. So if you think of these peptides as the docking stations within the spike protein that allow it to attach to the host cell. If they're in an open orientation, they're more likely to attach and to infect than when they're in the closed. Now, as you can see from this slide, this mutation, it's a single letter change to the viral DNA code. It's sort of an A to a G, as you can see from the diagram. It relaxes the connections between these peptides, making this open conformation more likely and might increase the chance of infection. So the little cartoon on the bottom shows the spike protein with all peptides closed. Basically, probably not a real infective state at that point. But when one peptide in pink, 2 peptides now in yellow, or 3 peptides, red, pink, and yellow, are opened, it would make this particular spike protein more likely to dock or attach to the host cell. So mutations seem to have an effect on the spike protein, most notably because that's the part of this virus, at least, that we worry most about in terms of increasing the infectivity. And the arrow on the bottom pretty much shows that. Likelihood of infection increases as these changes take place. So simply, summary statement here is that certain mutations can lead to a higher virulence of the virus. Now, it may not actually lead to higher mortality, but it could be a higher morbidity. I mean, we look at other viruses, the flu viruses versus the measles virus. Measles is much more contagious, although people don't die that much from the measles. So these variants have made this particular virus now more contagious than it was a year ago. And that's the worry. As it continues to be allowed to mutate, who knows what the next variant might be? And that's a concern many scientists have right now. So jumping to the next slide, some of the new variants of the virus are expected to occur over time, as we've already reviewed. Now, just to run through the points, some emerge, some disappear, while others persist. Just candidly stated, the more, fatal variants don't last long because they kill off the host. The host dies, is not allowed to spread. The ones that last the longest are the ones that are more contagious, yet not fatal. And that way they can continue to spread from individual to individual, and that individual is able to infect others. So changes to the spikes on the surface of the virus are what they mainly are focusing on with these variants, as we've discussed. It helps understand how the change to the virus might affect how it spreads and what happens to people who are infected. Of course, there's a lot of other variables in terms of how one can respond to a virus, and their underlying immune state and the overall health plays a key role. Now, multiple variants have been documented, US and globally, and you see the different variants listed. I think that's a nice outlay of the UK variant, South Africa, Brazil, and India. And just to comment on the India variant, that when the slide was really focused on was mainly in India. As we've seen, it's been a horrible situation they've had lately. However, this Delta variant had translocated to the UK, and now, of course, it's throughout the United States. I think I'm out of Nebraska. I think the last data was up to 30 to 40% of all new cases are the Delta variant. A lot of our cases in fully vaccinated individuals admitted to the hospital with COVID are the Delta variant. So what we're seeing here is a variant that is causing morbidity in individuals even after the vaccine, which raises a lot of concerns. And they just had an article in the paper yesterday, the LA County, 1 in 5 hospitalizations are fully vaccinated individuals who have the Delta variant that they're carrying. Just to go show that, yes, these vaccines are critical first line of defense, but it's kind of like driving a car. The first thing you do is you put on your seatbelt. The second thing, you want to make sure your brake works. I mean, you've got to have all the other pieces in play. So you want to be masking and keeping your distance, and you want to watch how much exposure you have to other people that may in fact have this virus. I'm pounding this point home throughout this talk because as a clinician, I want to do all I can to try to prevent the spread of this virus. Last point, the D614G mutation, the one we just talked about, is now ubiquitous, and it does increase the virus' ability to infect human cells up to 8-fold. So I don't know the instance with the Delta. It's got to be at least that, if not higher. And I think that as this virus is allowed to continue to replicate and spread within the unimmunized host cell, we're going to see new variants. As I mentioned, these RNA viruses like to mutate.
Yes, those are excellent points. And I think the conjecture at this point that I just heard is that we're about 3 weeks behind UK in terms of the spread of Delta. So hopefully we will get a better handle on it, but that remains to be seen. So probably our best, our seatbelt and our best safeguard is going to be making sure that we get as many people vaccinated as possible. So let's talk a little bit about some of the currently available vaccines. And again, this is a very evolving story. So we're going to see probably more and more changes within this and recommendations and information around safety, effectiveness, need for boosters and all of that sort of stuff. But if you could walk us through a little bit of what we know now, that would be extremely helpful.
Yeah, so this is I think a very important slide because this points out much of what's been done. As everybody's aware, a year ago, this process, a little over a year ago, was just getting started. The Operation Warp Speed, the prior administration instituted, was designed to try to find a vaccine that would work against this virus. This is an unprecedented event that's taken place in world history, in all honesty, to have these vaccines even available a little over a year after this particular virus entered the scene. So to go through the top, currently 3 vaccines are authorized and recommended to prevent COVID-19. Now, just to talk about that, these are what we refer to as emergency authorizations. These vaccines have not undergone full licensure, but I want to point out a couple of points on that because I have a lot of patients and actually healthcare personnel that wait. It's an emergency authorization. That means the FDA hasn't even approved it. So if they don't approve it, why should we? And I think people need to understand a couple points, and this is another side point, but I think important to realize that because these vaccines were released so quickly and produced so quickly, it takes time for the FDA to review all aspects before full licensure can be offered. And I was listening to the former head of the FDA just the other day on NPR, who stated that Pfizer, for example, just submitted their full licensure application to the FDA at the end of May. And he said it likely has nothing to do with the safety of the vaccine. It has to do with all of the packaging and the labeling and how to store it, because once it receives full licensure, it can actually be in any medical office, the doctor's office, for example, and they have to know how to keep it safe and how to keep it available for patients. So these vaccines, having nothing to do with their being safe or unsafe, just has to do with how long it takes to get through the FDA for this full licensure to be achieved. But the Pfizer-BioNTech COVID and the Moderna COVID are both mRNA-backed vaccines. What's really been interesting, and we've learned about these vaccines, just to talk a little more, has to do with their array of involvement on the spike protein. And they've shown that these particular mRNA vaccines have a broader range, a broader effect on protecting against multiple aspects of what they call the receptor binding domain on the spike protein from infecting the host cell versus the natural infection. So the natural infection, you're getting exposed to the entire virus, usually within the lung, whereas with these particular vaccines, you're getting just the spike protein you're getting exposed to in muscle tissue, giving the immune system a little more time to work on it. So there is a difference in terms of natural infection versus vaccine in terms of what effect it may have on protecting one from further infection. Now, the second point is a viral vector vaccine. And basically, that's the Johnson & Johnson. What we're seeing, and some of the AstraZeneca, the next point down, it means that there is a virus that transmits. It's sort of the chaperone, if you will, of the vaccine into the body's system. We have had some different complications with the viral vector vaccine versus the mRNA because they're two different mechanisms. The phase 3 clinical trials for the AstraZeneca and the Novavax, which is different entirely, that's using a subunit of the COVID protein to be exposed to. So it differs from all the other vaccines we've had so far. But as of yet, these AstraZeneca, Novavax haven't been approved yet in the United States. They're undergoing review, but the first 3 that we've mentioned have been. Now, they all quite likely will be approved at some point, not only here in the U.S., but around the world. And it's important to get these vaccines out and in the population, because different areas of the world are struggling. Certainly different communities here in the United States are struggling with vaccination. The last point is nicely stated, that the real world effectiveness data with the mRNA vaccines indicates, point 1, that after 14 days from the first dose, there is some partial immunization provided. Preventative benefits with the vaccine can be up to 80% effective. Full immunization with 2 doses, 90% effective. But what we're also learning is that in elderly patients, those over at age of 75, this condition called immunosenescence is a problem, meaning they may have their 2 doses, but they may not achieve a 90 or 95% antibody rate. That may be lower than that, suggesting that even after the vaccine, we still have to use caution. And I think that the vaccines are the number one mechanism we have available right now to prevent this infection, but it doesn't stop there. There's been a lot of concern about some of the side effects, and I'll just touch on a couple of the more common ones that my patients have expressed to me. One is this concept of myocarditis, which is inflammation of the heart wall. So we're seeing myocarditis with some of the vaccines. It's actually a very rare incident. The Israelis just released a press release within the last week or so showing that they're seeing myocarditis in post-vaccinated individuals. 24 out of 1 million was what their ratio was. Now, if we look back on the cardiac involvement of the infection itself, we're seeing maybe greater than 50% involvement of all comers who develop a COVID infection for having some effect on the heart. So the real question is, what is the safest option of the two? Do we get a vaccine that, yes, every vaccine has potential for some reaction, otherwise it wouldn't be a vaccine. It does institute or initiate an immune response in the body, which is natural. Yet, look at what the COVID infection can do and how unpredictable that is. There's also been some work, there's been some concern about fertility issues. I'm seeing a lot of my young female patients worry about long-term fertility risk. talking to my OB docs, there's absolutely nothing that they can see that has anything to do with it. And in fact, this is just jumping into the OB world a bit. There apparently is a protein on the placenta that genetically looks a little like the protein in the COVID itself, but they're so dissimilar. One author, he was an endocrinologist with fertility issues, said it's almost like confusing a mouse and an elephant because they're both gray. He said the immune system could easily distinguish the difference. He said there's no possible way that there's interaction. But once these types of pieces of information are leaked on the internet, people, they bind to these things and think that there's got to be some truth, when in fact no vaccine has ever shown to have issues with fertility. And in fact, it's the other way around. We're seeing COVID infections have a significant effect on pregnant women, on pregnant moms. Higher incidence of preterm deliveries, less than 37 weeks. And some of the male patients are having testicular, scrotal involvement, inflammation, and a lot of worries on their ability to, in terms of fertility issues down the road. So I think striking home the point that, as this slide is showing, these vaccines aren't perfect, but in such a short amount of time, they are the best thing we've come up with to help combat this worldwide plague of COVID infection.
Absolutely, yes. Thank you so much, Gary, for sharing that with us. And I know you'll be talking much more about some of the myths and misunderstandings associated with SARS-CoV-2 in part 2. So everybody tune in for that. And again, this is something that we're continuing to get a better appreciation of the true effectiveness and protective factors associated with these vaccines. So it is kind of an evolving type of discussion, and hopefully we'll maintain the level of effectiveness that we currently believe we have, but we have been seeing fully vaccinated people, to your points earlier, getting infected and then ultimately having some more serious presentation with different variants of the virus. So this, unfortunately, kind of brings us to the conclusion of part 1. We will be collecting, if you do have questions for Gary or for any of the information that's been provided for you today, please submit your questions so that we can make sure to address these. And in the absence of having that available right now, I will just throw it out to you, Gary. I know we've talked a lot about the importance of getting vaccinated, about protecting yourself, continuing, especially in those crowded population areas. Use your mask, do the social distancing, just be smart and be respectful and take care of yourself and others. Are there other final thoughts that you would like to share with our PsyQ community as we sort of wrap up this update a year and a half into the pandemic?
Well, of course. Well, Rachel, it's been a sobering experience for all of us in the healthcare industry, for every aspect of society. But I think the encouraging is that this will pass. We will get through this. The sooner we all work together to help achieve it, I think the sooner that's going to be seen. And so the final thoughts might be, if there are concerns that individuals have regarding the vaccines, sit and talk with your healthcare professional. Try to get those concerns addressed. There are some people who have certain allergies that need to be very worried, but that doesn't usually apply to the majority of individuals that we're focusing on. So that, I guess, would be my first point, that even if you're a healthcare worker or a provider out there, you've got doubts about the vaccine, fine. Try to explore what the reality is behind those doubts. And more importantly, look at the data of the infection that we're seeing. And I think number 2, these variants pose such a risk that we have to think of others. We simply can't be thinking of ourselves at this day and age, that we have to try to take care of the people around us, and especially those who are probably more susceptible in our society. So that's where the masking, the hand washing, the gloves, distancing, these are such simple measures that we should all continue to adhere to. And I think that's the best way to get through this.
Thank you for that. We really appreciate all of your perspective and your time today. And we look forward to hearing all that you can share as we try to quell or eradicate some of those myths in part 2, where you'll be discussing that with my colleague, Dr. Jacqueline Canning. And then please also tune in for part 3, where we'll have a panel discussion with Dr. Pattee, Dr. Gaurav Agarwal, and Kathy Day. So that'll be a really interesting perspective from psychiatry, neurology, and the patient caregiver advocacy stance. For more information or to request any other detailed information that is available on PsyQ, please go to psyq.org, and you can find a whole host of different types of events, slide decks, presentations, webinars, archived webinars, and all of that's there for your enjoyment and education. Please also download our PsyQ app so you can get all your resources in one stop on the go using our PsyQ app. It is available from the Apple iStore. You can also check out what we have ongoing now, really excited about, is the PsyQ podcast. So check those out, some really interesting deep dive information, and as they like to say, sort of spilling the tea with some of our healthcare providers who have been actively involved in PsyQ for years now. So a lot of really interesting information there. You can also connect with us through social media, multiple different avenues there, Facebook, LinkedIn. So we encourage you, Twitter, to take a moment and check out some of the social media if that is one of your specialty areas. Again, thank you so much, Dr. Pattee. Thank you for your time, your expertise, and sharing some perspective with us today on viruses, vaccines, and long-term consequences, an update on the SARS-CoV-2 pandemic. So with that, thank you, audience, for attending, and please tune in next time for more information, and keep yourself healthy and happy out there.